Hello, this is Dr. Glenn Jaffe, Robert Mockemer Professor of Ophthalmology and the Chief of the Vitreoretinal Division and Director of the Duke Reading Center at Duke University. Welcome to this educational activity, which is focused on the multidisciplinary management of uveitis. And joining me in this discussion is Dr. Robert Keenan, who is Associate Professor of Medicine and Clinical Lead of the Division of Rheumatology and Immunology here at Duke. Welcome, Rob.
Thank you for having me.
And Dr. Keenan and I see patients together in a uveitis clinic, and we also have one of our patients who is joining us today, Elizabeth Herndon. And welcome, Elizabeth.
Thank you very much.
The following audio is from a three-part panel discussion with Dr. Glenn Jaffe, Dr. Robert Keenan, and Ms. Elizabeth Herndon. This audio is part of a certified educational activity improving outcomes in patients with uveitis, strengthening the connection between ophthalmologists and rheumatologists in an era of new treatment options. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/HRP. A printable monograph, slides, practice aids, and other features are also available.
Uveitis is a significant cause of vision loss and blindness in the United States and worldwide, and it's critical to diagnose this group of conditions early and accurately so that you can classify it and to appropriately manage the condition. Uveitis can be caused by an infection or an autoimmune inflammation, and today we're going to be focusing mainly on non-infectious uveitis. So let's start by discussing the classification of uveitis. There are many different ways you can classify uveitis, but one of the more common ways is to classify uveitis based on the anatomic location, whether it's anterior, the front of the eye, intermediate, posterior, or panuveitis, which includes the front and the back. And the manifestations of posterior uveitis, for example, the retinal lesions and vitreous haze, is more associated with decreased vision than is anterior uveitis alone. I'd like to now turn to Elizabeth. And Elizabeth, can you please share with everybody who's watching how you came to be diagnosed with uveitis?
Yes, as a young child at age 5, I was visiting the pediatrician for a checkup, who asked if anything else happened to be bothering me. I mentioned that my eyes had been watery. He took a peek in and immediately told my parents to have me visit an ophthalmologist, who then diagnosed me with uveitis. I started steroid treatment immediately with eye drops, and also developed JIA about 2 years later. I did have cataract surgery and also my lenses removed. From there, I was corrected to 20/20 vision with contacts and glasses, and was fine until 2004 when the disease moved from the anterior portion of the eye to the posterior. I happened to be seeing a glaucoma specialist at Duke who referred me to you and have been seeing you since.
Thank you, Elizabeth. Can you remember if you were experiencing any other symptoms, for example, pain and sensitivity to light, when you were first diagnosed?
No, I did not have any symptoms of any kind when I was diagnosed.
And was uveitis in one eye or both eyes when you were first diagnosed and when it came back?
The uveitis was in both eyes.
So different types of uveitis present differently. Remember, this is a group of diseases. And in JIA, the type that Elizabeth had, or juvenile idiopathic arthritis, it's very common for the patient not to be so aware of things going on wrong. And if there's not severe inflammation in the front of the eye and the vision's pretty good, the patient may not notice that anything is wrong. And sometimes this is called a quiet uveitis. Anterior uveitis may present with pain, redness, and photophobia, which means bright lights bother the eyes. Intermediate uveitis may cause floaters and may cause decreased vision, particularly when there's swelling in the retina. And eyes with posterior uveitis may have decreased vision if the sensitive visual structures are affected, but it may also have no symptoms and may have no signs if there's no anterior uveitis and if the spots are not located right in the visually sensitive areas. When we evaluate patients with uveitis, we first measure the vision and pressure, which are like the ocular vital signs, and then we start from the front of the eye and move to the back of the eye. So the anterior chamber is evaluated first, and we determine the number of white blood cells in the front of the eye, and we also look for flare, which is protein leakage into the anterior chamber, and we can grade that on an objective scale so we can monitor from one exam to the next. A hypopion is like the ultimate manifestation of cells in the anterior chamber, and it's a layering of white blood cells in the anterior chamber, and it goes along with diseases such as HLA-B27 associated conditions like ankylosing spondylitis, which is actually the most common cause of an autoimmune hypopion uveitis. Behçet syndrome can also cause a hypopia and uveitis, and it's a classic finding in the disease, but actually not a very common one. Importantly, we need to differentiate a hypopia and uveitis on an autoimmune basis from one in which there may be an underlying infection, for example, following cataract surgery. With intermediate uveitis, as we move farther back into the eye, we may see inflammatory cells and haze in the vitreous gel, and there may be swelling in the central portion of the retina, which is called macular edema. And in eyes with posterior uveitis, we may see lesions in the retina or deep to the retina. We may see macular edema, and we may also see evidence of inflammation around the blood vessels. And with panuveitis, there's inflammation in the front, in the anterior chamber, and also the back of the eye. We do retinal imaging tests very frequently in eyes with uveitis, which is helpful in the evaluation and follow-up of patients with these conditions. The most commonly used retinal imaging techniques would include fundus photography, in which we image the retina and look at the lesions that we can then monitor over time. Fluorescein angiography, where we may look at leakage from the retinal blood vessels and areas of ischemia or non-perfusion. Fundus autofluorescence, which is based on the health of the retinal pigment epithelial cell. We do optical coherence tomography in almost all patients, and I would consider that a type of ocular vital sign because we obtain it so frequently and on nearly all patients. Optical coherence tomography can be thought of as in vivo histology because we're able to image cross-sections at high magnification of the retina and other structures, and we do this in a non-invasive way. In addition, patients with uveitis can have media opacity. It may be difficult to see the back of the eye, for example, because of vitreous haze or cataract. And in these conditions, we need to do ultrasound to better evaluate the back of the eye. These imaging modalities not only help to make the diagnosis, but they also help us to document and follow patients after therapy of this group of inflammatory conditions. Before we consider the systemic disease associations with uveitis, we need to make sure that there isn't an underlying malignancy or an infectious cause. And lymphoma and other malignancies may cause a masquerade syndrome, which means what looks like a uveitis, but may be based on an underlying different type of condition, for example, lymphoma. And if we have an older patient who has significant vitritis in an eye, and particularly if there's lesions under the retina or deep to the retinal pigment epithelium, these lesions may be whitish or yellow, we need to consider a potential underlying lymphoma. Often the imaging test, for example, OCT, will show lesions in the retina or at the level of the RPE, which may be suggestive of an infiltrate. And we may see changes on fluorescein angiography, which can show either subtle or more prominent changes that reflect the underlying retinal pigment epithelial abnormalities. Also, in patients who have been treated with corticosteroids, in whom we would expect a favorable response, when they don't get that response, we need to think about a disease like an underlying lymphoma. And in this situation, my threshold for doing a diagnostic surgical procedure to obtain a vitreous sample is low. I'd rather do a test and find out that it was negative for lymphoma than miss the possible diagnosis. So among the more common causes of infectious uveitis, you need to consider viral diseases such as cytomegalovirus, herpes simplex, and zoster, and then other conditions such as toxoplasmosis, tuberculosis, and syphilis. And we use specific testing for these different conditions. For example, for viral infections, we'll take a sample of the aqueous from the front of the eye or the vitreous, and we do PCR testing to look for viral DNA. For syphilis, we may do a VDRL or an FTA-ABS, and for tuberculosis, we may do quantiferon gold, a chest x-ray, or tuberculin skin testing, for example, the PPD. We determine the need for laboratory testing based on the clinical evaluation and then the imaging test. And then we generate a differential diagnosis or list of possible diagnoses, and then we do very directed laboratory testing to narrow down the diagnostic possibilities. Patients who have systemic symptoms and complaints may also receive directed laboratory testing, and we may also refer them to an appropriate specialist, for example, the gastroenterologist, dermatologist, rheumatologist, or pulmonologist. The systemic disease manifestations of uveitis always must be kept in mind. And Dr. Keenan, could you tell the audience some of the rheumatologic diseases that go along with non-infectious uveitis, and how can ophthalmologists pick those up?
Well, there are several. You mentioned a couple already. Behçet's is one. You mentioned ankylosing spondylitis and HLA-27 associated spondyloarthropathies. which is more common in young males. They'll present with low back pain or buttock pain. Sometimes they'll present with costochondritis or even chest pain, which is due to costochondritis. We've actually picked up several patients ourselves with their initial complaint being their loss of vision, but yet, upon further questioning, they've had low back pain for years and low back stiffness lasting 30 minutes, 60 minutes, etc. As Elizabeth demonstrated with juvenile idiopathic arthritis, or JIA, and although there's a slight male predilection, it also occurs in females. Sacroiliitis can occur, hence the name of JIA instead of JRA, and they can have a positive ANA, they can have a negative ANA, they can have a positive or negative rheumatoid factor as well. It's important that children, especially that present with arthritis or joint pain, are screened at least for uveitis, and especially if they're ANA positive. Other disease states that can also present with uveitis include sarcoidosis, and we see many patients with sarcoid. And sarcoid is a great mimicker. It can present in any various ways with whatever the skin manifestations, pulmonary manifestations, and of course uveitis and even arthritis. It's more common in blacks than whites, more common in female. It's not too uncommon to have posterior segment inflammation and even vasculitis or vitritis. Another disease state is reactive arthritis, which used to be called Reiter syndrome, and that's classically due to venereal infection, but it can occur any kind of gastrointestinal infection or even a virus can present prior to the symptoms. Other disease states include granulomatosis with polyangiitis. That one is more likely to present more like retinal vasculitis, and of course Behçet's you mentioned, and those systemic manifestations include ulcers in the mouth and genitalia, as well as acneiform type of skin lesions. Inflammatory bowel disease, as well as psoriatic arthritis and psoriasis, are also commonly cause uveitis.
So let's turn back to Elizabeth. And what were your arthritis symptoms?
They were in my right knee, left ankle. I had lots of pain and swelling in the mornings and was on a high regimen of aspirin daily.
How did it impact your daily life when you were diagnosed first with uveitis and then arthritis, and then you had the cataracts and the glaucoma?
As a child, I was pretty resilient. I think it's easier to deal with those things as a child than an adult. I continued on with my daily activities and school under great care.
Thank you very much, Elizabeth. So in this first segment, we've reviewed the diagnosis of uveitis and how to identify systemic causes. And stay tuned in the next segment, and we'll be discussing the treatment for this variety of conditions. Welcome back. Let's now discuss the treatment options for non-infectious uveitis. They include local therapy, and steroids are really the mainstay of uveitic treatment, particularly with local therapy. And we can give drops, we can give periocular steroid injections, meaning around the eye, we can give intravitreal steroid injections, we can place sustained release drug delivery systems. Potential problems from local therapy include elevated pressure and cataract, particularly with corticosteroids. However, because of potential disease-related systemic problems, many patients will need systemic treatment for the underlying condition and for the uveitis. So, Dr. Keenan, can you tell us some of the systemic treatments for uveitis?
The first line of therapy, especially if topicals aren't calming down the inflammation, are oral corticosteroids. And we use oral corticosteroids for both acute and episodic disease states. And usually if a patient's flaring and they're not improving with topicals especially, or if their disease activity is in the back of the eye or middle of the eye, we'll start oral corticosteroids at high doses, typically 60 to 80 milligrams. I try to teach other rheumatologists the same thing, where they're used to treating rheumatoid arthritis, for example. It might take 20 milligrams to get their joint flare under control, while it might take 80 milligrams for the same size patient to get their eye flare or uveitis flare to calm down. And we usually taper over the course of several weeks versus several days, and we don't like to go too fast because of the risk of rebound flares. And also, long-term steroid therapy at low doses might be appropriate as long as the low doses are around 5 milligrams, preferably less than 10 milligrams a day. And finally, if a patient is doing better with oral corticosteroids, especially, the inflammation's calmed down, yet they start to flare back up again. As we taper down, that they might need immunosuppressive or steroid-sparing therapy.
So, Dr. Keenan, what are the potential steroid-sparing agents that you might use to treat uveitis?
Well, there's several we can use, and it depends on where the inflammation is and what type of inflammation we're dealing with or what type of uveitis we're dealing with. But methotrexate is one of our common go-to medications, and that's methotrexate at the doses we use similar to rheumatoid arthritis patients. Also, we use azathioprine, mycophenolate mofetil, which are both common transplant drugs that we use. Cyclosporin is another medication. We use cyclophosphamide for more refractory disease and more severe disease. It's kind of one of our last resort medications. The majority of data for the effectiveness of immunosuppressive therapies for ocular inflammation disorders are from retrospective studies. So a lot of it's kind of anecdotal somewhat and based on just experience. There's also TNF inhibitors that have come into play in our diseases over the last 10 to 15 years, and they've been actually very, very good for uveitis patients needing systemic therapy. There was a retrospective study suggesting that with infliximab that showed that clinical remission could be achieved in about a little over 80% of the patients with recalcitrant uveitis, and with only a discontinuation rate of about 19% due to adverse effects including skin rash, fatigue, chronic infections, and even rarely drug-induced lupus. The use of this agent for uveitis in the United States is off-label, but it is actually approved in Japan.
Elizabeth, can you tell everybody who's watching how you were first treated and when you were diagnosed with uveitis?
Yes, as a child, I was treated with steroid drops every few hours daily. And then in 2004, when the disease moved from the anterior portion of my eye to the posterior portion, I did begin immunosuppressant drugs and steroids.
Dr. Keenan, can you comment on what led to the decision to initiate systemic immunosuppressive therapy for Elizabeth?
Well, it was basically we were having trouble, keeping her inflammation under control with topicals. The inflammation, as you mentioned earlier, is in the back of the eye, and sometimes topicals, and usually topicals aren't enough to keep that inflammation under control. And given the severity of inflammation and how long it had been going on, we decided to initiate immunosuppressive therapy to try to get the inflammation to calm down by another means. Did you ever receive treatment for your arthritis as a child?
Yes, I was diagnosed with JIA a few years after I was diagnosed with uveitis. Was on a high regimen of aspirin daily until about the age of 7, where I needed to have tubes put in my ears for regular ear infections. At that time, the physician wanted me to be off of the aspirin for 2 weeks, which I complied. I had the surgery and went into remission. Coincidence or not, we don't know. However, the arthritis has been gone from my right knee, left ankle since 1985.
That's good. That's good. So it was high-dose aspirin?
Yes, around 800 milligrams daily.
With JIA is one of those disease states where patients a lot of times will actually present with arthritis before the uveitis. And the uveitis, as I mentioned earlier, will be found incidentally by screening. And the variation is different from person to person, patient to patient, of when and how long they'll have the uveitis and how long they'll have the arthritis. And they don't correlate with each other by any stretch of the word. So you still have uveitis, unfortunately, but fortunately, your arthritis went into remission many years ago, where some patients might continue to have arthritis throughout their life, and then while others might have it for 10 years and then it resolves, and another one might have it, 2 years, 3 years, as you did.
So, Elizabeth, how has the management of the uveitis and any of the side effects that went along with it impacted your daily functioning?
I try to keep a very positive attitude throughout this diagnosis. While there are some negatives that come with immunosuppression, such as not being able to have children under this particular drug, and also because of the advancement of the disease, I no longer drive. I'm still able to work full-time and also have a meaningful life in other ways.
Thank you very much. Although most of the studies in the use of systemic therapies are retrospective, the number of randomized controlled trials are increasing. And adalimumab, for example, was improved in 2016 to treat non-infectious intermediate posterior and panuveitis. And this was a landmark because this was the first non-steroidal medication to be approved for uveitis. This treatment has previously been approved for a variety of other inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and JIA. The FDA approval was based on positive results from phase 3 studies, and the phase 3 Visual 1 study looked at the use of adalimumab in patients with active non-infectious uveitis despite steroid treatment for at least 2 weeks, which were then discontinued by week 15. The results demonstrated that the time to treatment failure was 24 weeks in the adalimumab group and 13 weeks in the placebo group. The patients in the adalimumab group were less likely than those in the placebo group to have treatment failure, and the outcomes with regard to the secondary endpoints also were less severe in the eyes that were treated with adalimumab, and that included the anterior chamber cells, the vitreous haze, the lesions in the posterior segment, and the best-corrected visual acuity. They all favored the adalimumab-treated group. The adverse and serious events were more common, as you might expect, in the eyes treated with the adalimumab. There were similar results in the Visual 2 study, and this study was a study in patients with inactive uveitis, and the idea was to decrease the corticosteroids and try and maintain the eyes in a quiet state. And in this group of patients, there was a decreased risk of flare-ups of inflammation when the steroids were withdrawn in the eyes treated with adalimumab. Like the other TNF inhibitors, the adalimumab is associated with potential risk of infection and malignancy. However, these conditions did not occur at a high rate in the phase 3 study. And there's an open label extension study called the Visual 3 study, which is designed to provide long-term safety data for patients who are treated with adalimumab and who also have non-infectious uveitis. There's a variety of other agents that are being investigated to treat uveitis, such as intravitreal sirolimus or rapamycin. This is an mTOR inhibitor, and in phase 3 data, the agent was effective to treat non-infectious intermediate posterior panuveitis, which was measured by vitreous haze, and the mean best-corrected visual acuity was maintained throughout the study in each of the dose groups. The majority of the subjects who received corticosteroids at the baseline evaluation were able to taper off the corticosteroids, and there were no unusual ocular adverse events that were observed. Anti-IL-6 or interleukin-6 treatments are also being investigated in uveitis, and in one of these studies with sarilumab, 38 patients with posterior segment uveitis that was non-infectious received 200 milligrams of the drug every 2 weeks, and this was compared to a cohort of 20 patients who received placebo every 2 weeks. And at 16 weeks, 64% of the patients in the sarilumab cohort had at least a 2-step reduction according to the standardized grading scales of vitreous haze, or the steroid dose was less than 10 milligrams per day compared to only 35% in the placebo cohort. Most impressive to me was that the patients with the sarilumab had improvement in the central retinal thickness, or the swelling in the retina that can accompany uveitis, through 52 weeks, and especially when those patients had macular edema or swelling at baseline. There's another IL-6 inhibitor, tocilizumab, which is also being investigated in randomized clinical trials for intermediate posterior and panuveitis, and we've had some very favorable experience with this drug, especially to manage the macular edema component, which can be very difficult to manage otherwise. So, Dr. Keenan, how can these newer treatments impact the management of uveitis, and where do you see them fitting into the treatment algorithm?
I think it's a great opportunity or a great option for patients in general, and it takes them away from some of the, at least from the oral medications, some of the GI side effects that are common with oral medications. In addition to, although they're immunosuppressive, they're targeted, therefore they don't necessarily put you at risk as some of the other medications do for infections, for example. So in the algorithm for treatment, of course, some patients might need to fail one medication or another, but at the same time, whether they can't get them off steroids or whether they have persistent flares every time you taper them off steroids, I think these medications even could potentially be first line, and especially if they're FDA approved to be so, mainly because the medications we've used to date, with the exception of adalimumab now finally, are all off-label uses of the drug.
So how, if you have a patient that has systemic disease associated with the uveitis, how would that affect how you decide how you're going to manage the patient?
Well, that makes it that much easier. So if you know a medication can kind of kill two birds with one stone, that's what we want to do. We want to use a medication that can actually treat the arthritis symptoms, for example, as well as the uveitis at the same time.
Thank you very much, Dr. Keenan. So now that we've reviewed the treatment of uveitis, we're going to discuss the importance of the collaboration between the ophthalmologist and the rheumatologist and with patients who they are managing. So stay tuned for the next segment. Welcome back. Let's now discuss the importance of the collaboration between the ophthalmologist and the rheumatologist in managing patients with uveitis. I can think of several different ways that this collaboration between the ophthalmologist and rheumatologist can occur, how they may communicate with one another. In rare instances, a uveitis specialist may be also trained in rheumatology or board certified in rheumatology, and there's some examples of that. But much more commonly, that's not the case, and the two specialties really have to work together. And most commonly, an ophthalmologist does not have a rheumatologist to work directly with him side by side, but may not be comfortable managing the systemic medications or the systemic manifestations of the disease. So in that case, they have to work with the rheumatologist who is likely at a remote location. Dr. Keenan and I have a unique relationship where we're able to see patients together side by side in the clinic. Dr. Keenan, can you describe how that relationship works where you and I are seeing patients together in the clinic?
No, it works out to both of our advantages as well as, more importantly, the patient's advantage. The patients, I get a lot of feedback from the patients typically that they love seeing both of us together. And even some patients who had a pre-existing rheumatologist might actually even prefer to see myself just because they can see both of us together at not only convenience, but also the communication that's there between us. And that is a big advantage for the patient to have us in the clinic at the same time. You can directly tell me what you're seeing or not seeing, or I can even see sometimes what you're seeing, and we can make dose adjustments or start medication accordingly. The problem with communication when this in this scenario is when a rheumatologist is separate from the ophthalmologist in different clinics, and they might not even actually know each other. You know, the ophthalmologist is referring a patient to the rheumatologist, is that rheumatologists a lot of times doesn't understand the opto speak, so to speak, their notes and understand what actually is going on. It's difficult for a rheumatologist who's used to seeing physical manifestations of a disease. It's easy for them to treat that, but when they can't see anything happening, it makes it much more difficult, and they're usually a little leery to do so. If they develop a good working relationship with the ophthalmologist, whether it's via phone communication, e-communication, whatever the case may be, then there's more trust involved, and therefore the rheumatologist is more likely to say, okay, well, if this is what your ophthalmologist is saying, this is what we're going to do, even though they can't actually see what is going on in the back of the eye themselves. And that's usually where the biggest obstacle is between the communication as well as the relationship with the ophthalmologist and the rheumatologist.
Thank you very much. Elizabeth, you've been seeing both Dr. Keenan and I together in the clinic, and maybe you could tell the audience how that's been working out for you.
Yes, having two doctors side by side is extremely beneficial. The communication is there. I know that the team approach is available, and I can ask as many questions, whether it be systematically or about my eyes.
Thank you. Dr. Keenan, how would you give advice to ophthalmologists when they need to communicate to the rheumatologist, but more importantly, when they need to first evaluate the systemic diseases and then make a decision about whether they need to refer to a rheumatologist?
Well, if the ophthalmologist has actually found some symptoms or signs of the patient they're having systemically, they can pass that on to the rheumatologist as well. But I think more importantly is that when they send their notes or communicate with them, whether it's by phone or email or e-communication through the medical record, they kind of, in layman's terms almost, tell them what's going on. They have posterior uveitis, or they have inflammation in the back of the eye, and they have active disease, for example, or they were refractory to topicals, and also list the differential diagnosis, what they feel like it might be going on as well. That would greatly help the rheumatologist and also help them decide which therapy is the best therapy for that patient. I think ruling out infections is a big one too, and documenting that infection, or this is not typical infection or this does not look like an infection or there's a very, very low suspicion of infection would all be worthwhile and to place in the note and communicate to the rheumatologist.
And when should an ophthalmologist make the decision that he needs to refer that patient to the rheumatologist?
Well, one big reason is if the patient's put on oral corticosteroids by the ophthalmologist and they can't get them off. We see many times in clinic ourselves that patients come to us with on 30 milligrams of prednisone a day for months and months, and there's data that suggests that patients with posterior intermediate uveitis can average around 30 to 40 milligrams of prednisone a day for greater than 3 months, even up to 6 months, before actually being considered for systemic therapy or steroid-sparing agents.
Yeah, certainly we have patients who go on with treatment that probably should have been modified long ago because the decision to refer isn't made early enough. So on the flip side, when should the rheumatologist refer a patient to the ophthalmologist?
Well, as I mentioned before, pediatric rheumatologists with a patient that presents with knee pain or joint pain in general should definitely send to the ophthalmologist for screening, especially if they're ANA positive. Rheumatologists, adult rheumatologists should do the same thing, especially if the patient's complaining, has psoriasis, for example, or psoriatic arthritis, or ankylosing spondylitis, or Behçet's especially, and they're complaining of any kind of visual symptoms, they should be definitely referred to an ophthalmologist.
And do you have any particular advice for rheumatologists who are seeing their patients in the clinic with systemic disease and then they develop potentially signs of uveitis?
Get them to the ophthalmologist and communicate with them directly. Uveitis specialists specifically, if possible, whether they're a retina specialist or a cornea specialist, if you can actually pick up the phone and call them, I think that does a lot to get the patient in quickly and potentially start treatment sooner than later. And a lot of times that's the difference.
Great. So I'd like to get back to Elizabeth to talk about the collaboration with the ophthalmologist, the rheumatologist, and patients. So from a patient perspective, what's the most important thing to you when you're seeing your physician, your ophthalmologist, and uveitis specialist, and the rheumatologist with respect to your care?
I think the most important thing is that I know that two different physicians are working towards the betterment of my health and my vision. I think the time that's spent together and the fact that my time can be spent during one appointment with two doctors is extremely beneficial and helps in all forms of communication.
So let's say you have that type of communication and interaction, and then what do you hope to get out of that?
I hope to be able to learn how to manage my eye disease and my health better so that I can tell if anything goes awry, I can immediately communicate with both doctors, or B, I can continue on the path of specific medications and keeping myself healthy.
Thanks. So I would then ask, do you have any specific thoughts or recommendations from a patient perspective of how for the physicians who are treating patients with uveitis?
I think it's always good for everyone to be open in the conversation, and the benefit has been the time that has been spent with me and not feeling like I am just another person, but I am part of a team of professionals who are trying to help me.
Thanks. So can you now let everybody know how you're doing now?
Yes. My uveitis is stable under the care of both doctors. I continue to work full-time, and am happy to say that I'm running my first 5K next month, so I try to be very healthy as well.
Thank you very much, Elizabeth. Those comments regarding your own personal story and then your perspectives and advice, I think, are very valuable to physicians who may not get to hear that kind of story from the patient's perspective. So in conclusion, uveitis is an important cause of vision loss, and it has to be accurately identified and aggressively treated. As you've heard, it can be associated with rheumatologic and other systemic diseases that you have to take into consideration when you're managing the patient with uveitis. Fortunately, the pharmacologic options for uveitis have expanded, and I'm hoping that they'll continue to grow in the future. Increased collaboration among ophthalmologists and rheumatologists and their patients can help to improve outcomes in this group of inflammatory diseases. Well, that ends our discussion for today. I hope you found it informative and useful, and thanks again, Rob and Elizabeth, for your important and valuable insights. Thank you very much for participating in this educational activity on the multidisciplinary management of uveitis.
This activity has been jointly provided by the University of Cincinnati and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/HRP. This activity is supported by an independent educational grant from AbbVie.